Good afternoon, my name is Joost Boormans. I'm a professor of urology at the Erasmus Medical Center, Rotterdam, the Netherlands. Today we are here at EAU and we will discuss the plenary session we just finished, which was on novel technologies, affordability versus benefit. And it's a great pleasure to have with me here Dr. Pietropaolo from Southampton, England, and Dr. Andrea from Vienna, Austria. And if you allow me, David, ladies first, I wanted to start with you then, about centralization. We had that already addressed a bit in the discussion. Centralization of complex surgical procedures has proven benefits. And what are your thoughts on centralization when applied to stone disease?
Thank you, Joost. First of all, thank you very much for having me here and for EAU for inviting us for this nice discussion. We've talked in the session about centralization, and this is very important in particular in complex cases in my view, because like for example in the UK we have places or hospitals, big hospitals with some sort of diseases or procedures are centralized. I think this allows to have a better understanding of the procedure, but also much more skilled surgeons will be focusing in the same hospital in order to treat the disease, but also having the best equipment, so the high quality and latest development of technology would be available in order to offer the best outcomes to the patient. Yeah. What we were saying though, sometimes this is difficult to achieve, so in particular in other countries it's difficult to have a standardization everywhere. So, but that's the aim for our patients.
Yeah. Because you showed us some high-tech technologies here to treat endoscopic treatment of stone disease. At the end of the plenary session, we had our colleague from Professor Lesrek from Morocco, who showed us all tips and tricks on how to reuse very simple things we all have all around the world to use. What are your thoughts on that?
Exactly. This was an amazing talk, and I have to say it was very inspiring. Because we always think about technological development, how to improve, and then the cost increases, of course, and some countries can afford that, some others don't, and it's a shame that this will affect our patients. So this concept of trying to do the best with the tools you already have, and maybe trying to create, so open your mind to new ways to using the equipment you already have in order to still achieve the same surgical outcomes for patients, I think is revolutionary, and probably we should think about it because so that we can decrease the cost even in countries where we have access to the newest technologies.
Because David, you explained us how to calculate the quality of adjusted life years, but if you take into account the things Amelia just mentioned on really specific high-tech technologies versus reuse of very basic material, what are your thoughts on that from a cost-effective perspective?
Yeah, sure, thank you. Yeah, we had indeed this interesting discussion also about that, about the cost effectiveness. And basically the methodology of cost effectiveness implicates not only the cost of the procedure, but also the quality of life. So we also have to consider also this. So if we consider only the cost, we're talking about proportions. So how much does a reusable device cost and how much does a single-use device cost? And this is easily to calculate. And also the carbon footprint and all the stuff that you nicely showed today. If we're talking about cost effectiveness, so we want to talk with stakeholders about the prices and what we want to integrate, we would also need data on the quality of life or all these other outcome and metrics that measure also this aspect. And I think in this scenario would be a little bit more difficult to evaluate because there is a lot of surgical biases within it. So if you also consider also the reinfection and so that you nicely show there is no difference between the reusable and the single scopes. At this point, sort of an analysis would probably not be the most appropriate one, but at least a very basic analysis on how much indeed one device costs, and so that just the proportion would be sufficient in this scenario.
Because Dr. Villaseca had his talk on novel therapies for non-muscle invasive bladder cancer and showed us the extreme high cost of some novel technology. So adenovirus delivered intravesically, and also this IL-15 super agonists. I believe $600,000 for the first 2 years. Obviously, that's US, and that's probably different from Europe or other parts of the world. what's your perspective on these extreme high costs for a localized disease?
Yeah. Thank you for addressing this, because this is a very timely and important question. Of course, the data that we now have are all from the phase 2 trials for these novel drugs that are now on the market, and they are only FDA approved, they're not EMA approved, because of the trials that were conducted. So the data are extrapolated from another healthcare system. So we have also to consider this diversity of the healthcare system. So we're comparing an American system to Europe, which has not only in the countries differences, but also within the countries and regional differences in terms of reimbursement and everything. We conducted recently a cost effectiveness analysis on this topic, so comparing these new drugs that are available. So in the case of of BCG failure, are these treatments more cost effective than radical cystectomy? Well, as we discussed earlier in the session today, when you're conducting a cost effectiveness analysis, you do not have to consider only the cost of the intervention itself, because of course this price scares everyone, but you have to consider the lifetime of the patient. So a patient with a non-muscle invasive bladder cancers who fails a BCG treatment has a high rate of progression, and so there are also other treatments that will occur in his lifetime. Systemic treatments, because the risk of metastasis is still at least 20%.
You have to cover the whole.
You have to cover the whole lifetime, and this is why the cost effectiveness analysis are important, and because they take into account all these other interventions that will occur in this period. So you're talking about the treatment strategy, not a specific drug. So you're not focusing on the proportions, as we said before. How much does the drug cost? But how does this treatment strategy, so with all the following failures or whatever sequences that will come afterwards. So this gets all integrated in this cost effectiveness analysis. What we showed is that at the threshold of the willingness to pay of €100,000 or $100,000, so if the Global bodies accept per patient to pay 100,000 for the specific strategy, all these new drugs are indeed cost effective.
You're right.
Because they increase dramatically the quality of life of our patients. Caveats, these are only data on 2 years studies maximum. So we do not know what will be in the long term. So this we need more approval in Europe or about the field, and we have to need to see real life data on how these drugs really behave and how is the proportion indeed of failure and the sequencing. Of course, we don't know that.
Thank you. Well, Amelia, back to the patient. So patient education, is it important regarding the introduction of novel technologies? Because sometimes patients have quite high expectations. For instance, robotic surgery, they sometimes have the impression that the robot will solve all issues and there will be no complications. And so I was wondering what your thoughts on that, and could you also reflect a little bit on the talks of Declan Murphy, who also discussed patient communication of novel techniques for patient communication, like with avatars or with AI or digital podcasts? Absolutely,
this is a key topic in my view. Essentially, the problem at the moment is patients have access to a huge amount of information through internet, YouTube, and some of these channels are not controlled, they're not certified to give medical information. So they risk to get the wrong information or to be totally misled in their choice of treatment. So our role in this case is to use technology and new technological advances, as was shown in the session by Declan, to guide them. And I think this is very important in order to have a real informed discussion and to give them a way to choose where the best treatment, having an informed decision from their side. So what I think would be very important, as Declan showed, is to use artificial intelligence for that. And what we do in Southampton, for example, we use virtual reality to do counseling of surgical procedures for patients, because most of the time patients don't know exactly what the anatomical area that you're going to operate, or what's going to happen
Do you
before.
also use different languages, like was shown?
That's this next step.
Next step.
We are now creating in every language, like 17 languages, including dialects like Hindi or Punjabi. And with the virtual reality, they will see a video in 3D showing themselves immersed in a treatment. Well, they will see what happens to their body. They will see possible where is the setting of the procedure as well, possible post-operative complication, post-treatment complication, and hearing, of course, a description that will be done for now in English, but the next step we'll do in different languages.
Great. So you show them how the stone is fulgurate, for instance, in the double J stand?
And it flashes and it moves down the ureter, the blood in the urine, the double J, etc. And so they've done a study to see their satisfaction of patients who had this virtual reality counseling compared to patients who just had a normal paper consent form, and they are much more satisfied, but also they have less level of anxiety having the procedure compared to patients who don't. So I think all this technology, including, of course, avatars, videos, artificial intelligence, we can send to the patient, for example, a video before they come to the procedure. There are many more tools that we will use in the future, and this will all help the patient to have the correct information, because the issue and the problem happens when patients come to you already knowing, I want that procedure, just because they've read something on a newspaper without knowing anything else, knowing only the benefits. And we don't have to, we need to make sure they know the whole picture, they have a wide variety of choice in front of them, so they can make an informed decision with us.
Great, David, to switch gears, we had a talk on hypofractionation for prostate cancer, delivering curative treatment to the prostate in 7 fractions, 1 week of treatment. Do you think there's still a future for radical surgery in prostate cancer?
Yeah, thank you very much for this very tricky question that you're asking, and also from a urological surgeon perspective. Definitely. I think we can break down this to 3 points. We have to consider the oncological, the outcomes, clinical outcomes of the patient itself, the cost of the treatments, and the logistics. So speaking about the outcomes, what we have seen from all big trials like PROTECT trials, whatever you will offer to this patient, being radical surgery, being radical radiotherapy, oncological safety is there. So this is out of discussion. So what we are talking now is about the toxicity, and this again is always the communication with the patient, so the discussion what we also conduct every day in clinical practice. So you have to inform the patients what are the differences in toxicity derived from a radical radiotherapy, but also from the surgery. Then you have the salvageability, let's call it like this, so salvage treatment that you can offer to the patient. So in the case of radiotherapy, we always argue surgery will be more difficult, but the other case is always applicable. But we have also seen that in targeted lesions with new systems as algorithms, they can also target recurrences within the prostate very well. So this will always be an open debate. And then going to the costs, if we compare now radiotherapy with radical prostatectomy, we have to be fair, we have no cost effectiveness analysis in this field. So we actually cannot really answer. There is on the one side the disposables materials, and the robot is very cost, but also the acquisition of new radiotherapy machines on the long term may be better. Can be, but we do not know this. So and then it's not only about the treatment itself, but also the follow-up. Maybe follow-up strategies will vary between these populations, and also we have to consider the patient selection within the risk groups. So lower risk patients will maybe benefit for both. Higher risk could be better to treat with radical surgery. This is also always open question, but there has to be discussed with the patients. And then the logistic, not everywhere in every country you will have access to both or one of the both, so this will also bias a little bit the direction.
Right. Thank you. Well, we're almost coming to an end, but I have a final question, because we started this morning with a lecture by Professor Daban from Barcelona, and she showed us also not only the aging population, but also the aging of medical doctors. You're both Italian by native, and what struck me was that the MDs in Europe are tend to get old, but especially in Italy, a lot of MDs are 65 plus in the upcoming decade. So we will face shortages of not only nursing personnel but also MDs. What are your thoughts on that, Amelia?
Yeah, it's interesting you're saying that, because whilst this data came on the screen, we both looked at each other because we're both Italian, but we both left Italy, which is another issue that Italy is facing, that some of the young doctors leave to go abroad for training and then sometimes they don't go back. However, this is already an issue that we see even in the news, but it's being addressed, trying to train more people so they've improve the access to the university in order to have more doctors, and I guess in the future will help. But then we don't want to go too much in the politics discussion, because then it's difficult. But of course,
and de-escalation of well, for instance, follow-up. There's an interesting trial from Denmark showing that urine testing is as good as cystoscopy in high-risk non-muscle invasive bladder cancer.
Oh yeah. This is another very, very, very interesting question at an opening, and indeed Denmark showed that with a urinary biomarker in the setting of the follow-up, and this is the first randomized trial in this field, that you can indeed reduce the number of cystoscopies in this follow-up without compromising oncological outcomes. First study in this field, but we're looking forward to see new data on this and maybe see if we can integrate this also into clinical practice. But it's definitely one step moving forward to the de-escalation, as you mentioned, so to be more effective and cost-saving at the same time, and reduce the patient's burden.
Well, I would like to thank you very much for your contribution this morning and also here in the interview. It was great to have you here. I wish you safe travels back home, and to the people at home, I wish you well and have a nice day.
Thank you very much.
Thank you very much for having us.
Thank you.